take a deep look at how cardiovascular computed tomography can help your patients. Join one of SCCT's hands-on workshops to get real case experience. With virtual access to reading software, learners interact with image-based cases while being guided by experts. SCCT workshops cover a wide range of topics, such as coronary evaluation, plaque features, grafts, valvular heart disease, transcatheter valve planning, structural heart disease, congenital heart disease, masses, pericardial pathology, and other commonly encountered clinical scenarios. All workshops include case credit and CME. Visit scct.org/workshops for more information. That's scct.org/workshops.
Well, hello there, listeners, and welcome back to The Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Alastair Moss, and I'm a cardiologist in Leicester in the United Kingdom.
And my name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. Today, Alastair will be providing his insight and his expertise on something very exciting, some recently published data from the recent ESC 2022 annual meeting on fluoride PET CT imaging.
That's right, Praveen. The PREVER study, the predict of recurrent events with 18F fluoride to identify ruptured and high-risk coronary artery plaques in patients with myocardial infarction, was the first multi-center study to establish whether coronary 18F fluoride positron emission tomography can identify patients at risk with a recurrent myocardial infarction. This was a study that was run by investigators at the University of Edinburgh, of which I was one of those investigators, alongside the chief investigator, Professor David Newby, who is well known to our audience for the work that he's previously done on Scott Hart. And so this was his new headline study, which was recently presented at the European Society meeting.
Excellent. So for some of the listeners in our audience that may not be as familiar with this specific technique or really cardiac PET in general, why don't we start with a brief primer? Let's first talk about what 18F fluoride PET imaging actually is, and potentially some of the differences between fluoride as a radiotracer relative to other radiotracers that some of our imagers might be more familiar with, such as FDG or rubidium, other viability and perfusion agents.
Of course, Praveen. So we normally spend most of our time talking about cardiac CT on this podcast. And obviously with that, what we're doing is we're producing a whole stream of photons that pass through a patient, and then we can measure them with a detector on the other side of them, 180 degrees apart. The difference when you're using radioactive tracers like 18F fluoride or fluorodeoxyglucose, which is often a workhorse tracer for a lot of oncology scanners, is that you inject the radiotracer intravenously, and this then binds onto a target within the body, and then it emits a positron which travels a very short distance from where it's found its binding target, and then you get an annihilation event, and from that 2 gamma rays are produced. And with fluorine label compounds, those gamma rays are emitted at a very specific energy of 511 kiloelectron volts, and we can detect those gamma rays using a very high temporal resolution scanner called a PET scanner. And there have been a lot of developments in PET scanners of late. And the most recent one is that they now have larger CT components attached to them, such that as well as doing the PET components, we can also now do coronary CT angiography. And we've had a lot of expertise setting up this coronary CT angiography program in Edinburgh, where we use the standard approach to doing a CT scan by giving iodinated contrast. And by using that structural CT image, we can then add a PET image on top of that to do what's known as hybrid imaging. So you're using all of the benefits of the CT scanner, where you can get really detailed structural information about the state of the heart arteries, whether there's a large amount of plaque there, subtyping that plaque into either calcified or non-calcified components, and then also using a tracer to work out what is the metabolic activity within those segments within the coronary arteries. We've done those in these studies in patients who have a range of disease, looking at patients with aortic disease, and also in patients who have a prosthetic valve disease. And we found that in those who have aortic valve degeneration, or in those who have got aortic stenosis, we see quite intense activity because this is a calcifying process within the valve. We had a very serendipitous moment when we actually were doing a valve study, and that patient came in, and we found that actually one of those heart arteries lit up like a Christmas tree. And to our surprise, we found out that actually 2 weeks prior to coming in for the study, they'd actually had a heart attack. And the area that lit up was very well co-aligned with the artery that was stented for treatment of their ST elevation myocardial infarction. And so we went on to do a smaller study, a pilot study using around about 40 patients, where we find actually that patients who had heart attacks had lots of these lesions that lit up within the heart arteries. And actually, there was really good co-alignment between the plaque that ruptured and the type of heart attack that they had, such that if they had an anterior myocardial infarction, we found that there was really good co-localization with the left anterior descending artery. And if they had an inferior myocardial infarction, we found that there was good co-localization with the right coronary artery. But this was already pilot data, and we wanted to go on and validate that further. And this was what this study, the PREFER study, was all about.
Got you, Alastair. So to be clear here then, the fusion imaging using 18F fluoride you're discussing is a fusion of coronary CT angiography and metabolic imaging using fluoride. But fluoride here is going for the plaque in the coronary tree, not what some of our imagers may be familiar with regards to myocardial metabolism. For example, myocardial viability with an FDG study or perfusion with some other agents. If that's the case, could you go into a little detail as to how fluoride pathophysiologically and biochemically may relate to coronary atherosclerosis?
So what we found is that the way that fluoride binds within the cardiovascular system is predominantly via fluorination of hydroxyl groups. And the most ubiquitous source of hydroxyl groups within the body is within hydroxyapatite. So this is a type of calcific mineral which is commonly found within bone. And so historically, this tracer has been used for the past 40 to 60 years for patients with oncological metastases and looking to see whether they have bone lesions and then using that to stage their type of cancer. And it's also been used in osteosarcomas as well to see, what the intensity of the bone activity is like. But it's never really been used in any clinical setting to look at cardiovascular disease pathology. And what we know about cardiovascular disease pathology is that obviously there is quite a strong inflammatory driver for coronary disease in particular. And that inflammation results in calcification being laid down within plaques. And we can clearly see that on patients who have lots of coronary artery calcification on CAT scans. And so the question that we had was, well, is this just telling us about essentially a coronary artery score, or is this telling us about something different? And the information that you get from using 18F fluoride is that actually it doesn't tell you about these large bits of calcium that you see on the CAT scan. It tells you about microscopic calcification. Actually, it's nanocrystalline calcification because it's almost below the level of a lot of micro-CT. And the sort of flecks of calcium that we're looking at are hydroxyapatite particles of less than 500 micrometers. And when you have this being laid down within cells, then there's a very high surface area for the sodium fluoride to bind onto. And it binds irreversibly, and it gives you a very clear signal as to where you're getting this microscopic calcification, which predominantly tends to be within non-calcified or within partially calcified plaques. So at an earlier phase, before you get the layering down of macroscopic calcification that you see on the CT scan.
Excellent. With this background in mind, can you reiterate the research question that was being asked in the study that was recently presented at ESC 2022?
Yeah, so we've known for a long time that when patients have a heart attack, there is quite a high risk of them going on to have a second event. And we've tried to be able to quantify what that risk is based on a number of anthropometric variables that we can collect about a patient, and they tend to be formulated into a scoring system. The most commonly used one tends to be the GRACE scoring system. However, the parameters that it picks up really are based either on age, and as you get more advanced age, your risk goes higher, or whether you have features of cardiogenic shock, either with signs of admission or being related to whether you need diuretics during the course of your early admission. And this score is very good at predicting hard outcomes like cardiovascular mortality, but it's not very good at predicting recurrent myocardial events. And so we wanted to use a precision imaging approach using this type of therapy to say, can we more accurately predict those who are going to get heart attacks? And if they have a high amount of this tracer, they're going to have high metabolic activity. If they have low amounts of this tracer, they'll have low metabolic activity. And so the key research question was, do patients with high metabolic activity have more heart attacks than those with low metabolic activity?
All right, fantastic. With that in mind, what sorts of patients were included in this study?
So as you can imagine, Praveen, when you're setting up these type of studies, we set it up as a controlled trial for an investigation of medicinal products. So we had really strict inclusion and exclusion criteria when we actually formulated the study at the outset. And when we were thinking about who we wanted to recruit, we actually kept the inclusion criteria actually quite broad. And so we said anyone over the age of 50 who was within 21 days of a type 1 myocardial infarction. So that's a heart attack which has been related to a plaque rupture event. And we also wanted to make sure that we were capturing those who had higher risks of having events. So we wanted people with either proven multivessel disease, so they'd either had to have treatment for one or more heart arteries, or they'd had coronary artery bypass surgery in the past. And that group in particular, we know at very high risk of going on to have recurrent events. We tried to make sure that we could treat this as almost an all-comers study. So for the majority of the patients who would be coming through our service, so the patients that we excluded were those who were pregnant or breastfeeding or childbearing potential, and those who wouldn't be able to have iodinated contrast due to having a low creatinine clearance, so an eGFR of less than 30 mils per minute per 1.73 meters squared. Otherwise, we were quite keen to try and make these as broader picture of the patients who are coming through our practice as possible.
To clarify, Alastair, the patients that you've included are those that have already had an event. Is that correct?
Yeah, so it's those who had just had a heart attack. So we wanted people who had had a heart attack, and what we wanted to do was see what their risk of a second heart attack would be following this event. So we're looking for recurrent heart attacks in a group who had recently presented with, an MI.
Got it. Okay, well, very good. What were the major take-home points from the results of the study?
So the study was a multi-center study, which we conducted across 4 countries. It was 9 centers. It included centers in the US and also within Europe, as well as in Australia. And so it was really a broad application of this imaging technique across multiple sites. We found that in the 704 patients who we recruited, 60% of those, so that's 421 participants, had increased plaque activity using the fluoride tracer. And after a median of 4 years, we found that 141 patients had a primary endpoint. And we define that primary endpoint as either cardiac death, non-fatal myocardial infarction, or unscheduled coronary revascularization. When we looked at comparing the events between those who had high fluoride activity and low fluoride activity, we actually found that there was no demonstrable association with the primary endpoint. So the hazard ratio was 1.25 with a 95% confidence interval of 0.989 to 1.76. But we did notice that actually this was driven by an unscheduled coronary vascularization rate being equivocal between the 2 groups. So the hazard ratio for unscheduled revascularization was, the mean central estimate was 0.88. I think the really, really fascinating finding about this study was actually that there was an increased risk of cardiac death or non-fatal myocardial infarction in those who had the fluoride uptake. And that was a hazard ratio of 1.82 with a confidence interval of 1.07 to 3.10. So that was a p-value of 0.028. So it was statistically significant.
Wow. So to restate, the patients that had demonstrably higher amounts of uptake based on the fluoride PET imaging, they had a higher predisposition towards having a subsequent event compared to those that did not have demonstrably higher uptake. Is that correct?
That's correct. So there's almost a twofold increase in you having a heart attack or dying from a cardiac death if you had high fluoride activity versus low fluoride activity, which is quite a striking phenomenon because the differences between these two groups was actually pretty minimal. They were slightly older in those who had higher fluoride activity, and as a result, as you could be expected with that, the burden of disease may have also been slightly higher. But actually, it would be quite difficult to differentiate these two groups just looking at them as they come through your clinical service. And so to find that you've got an imaging technique which can potentially tell you whether you're twice as likely to have an event within the next 4 to 5 years is a really powerful tool. And we're really excited by this result.
Yeah, that's incredible, Alastair. It's pretty powerful to think that a metabolic imaging technique can be utilized to pretty robustly evaluate patients for downstream events that they may have. However, given with all trials, I think it's important to understand what the potential limitations of this study were. With regards to the conclusions we've made thus far about fluoride imaging potentially being predictive of subsequent events, do you think that the study was adequately powered to make that claim? And subsequently, was the analysis being done on the images reproducible such that, both you and I living in different countries could achieve the same results given the same patient?
So they're really good questions, Praveen. So one of the ways that we set up this study was actually to have a primary endpoint looking at cardiac death and non-fatal myocardial infarction. And in order to do that, you obviously have to do a power calculation at the outset to estimate what your sample size is going to be. And that's to give you a guide as to what you think the number of events that you will need to accrue over this study will be to give it a confidence to reject your null hypothesis. We actually found when we did an interim analysis, then actually the event rate was a lot lower than we first anticipated. So we'd seen within retrospective cohorts that we'd done for real-world populations that approximately 1 in 5 people would go on to have a cardiac event within a short to intermediate term time frame. And we found that actually our event rate was probably slightly lower than that. And so in order to make sure that the study was adequately powered, we could either do one of two things. We could either accept the fact that we'd run the risk of being underpowered, but potentially have a difference between those two groups if we left the trial as it was. Or we could potentially modify our primary endpoint. And this is something that we've seen in other studies like ischemia, where they have made sure that for these heavily invested studies, the outcome that you get is appropriately powered, and therefore it's a marker of robust science. So our statisticians gave us advice on this, and by including the unscheduled revascularization in the primary endpoint, there was a 3-prong composite as opposed to a 2-prong composite, and that meant that we had sufficient number of events to be able to make a more firmer conclusion. One of the things that we obviously found was that, by bringing in an endpoint that may not necessarily be related to the biology of disease, so putting more stents in may not actually change the activity of fluoride, and therefore it may not potentially be that significant in terms of its impact on whether you will end up needing, a lesion for stable disease or not. We could have potentially, made ourselves prone to that type of error. But I think it's really important to say that actually it's just a marker of good science to make sure that you're really open and you declare what you're doing as part of the study. And this obviously has to be validated through a number of different mechanisms, including having the protocol signed off by our authorization authorities. With regards to the reproducibility, we have actually done quite a number of reproducibility studies using this type of imaging. So we've done that at the plaque level, where we've done test reproducibility, and we found that actually the scans are within around about 15% of the measurement, which for a coefficient of variation to be under 15% for an imaging test is actually really good and very robust. But we've also looked at this on the per patient level. And the per patient level is using a technique called coronary microcalcification activity, which has been validated by our colleagues over in Cedars-Sinai. And that is actually got good retest reproducibility as well. So it's a marker that can be measured across sites and across the world. And it's a relatively stable marker.
All right. I'm sure many of our listeners are making comparisons between what you're describing in the fluoride imaging space and what we're actively researching in the CT alone space would be advanced plaque characterization and quantification. Examples could be total plaque volume evaluation of the percentage of low attenuation plaque, or just something as simple as a calcium score. Can you help draw some parallels between the fluoride imaging PET work that you've just discussed and some of what our listeners may be familiar with in the advanced plaque characterization world?
Certainly. So the design of the study was following on from a trial that was run by Greg Stone called the Prospect trial, where they did a natural history study looking at lesions that could potentially progress following a myocardial infarction to cause recurrent events. And they found that the lesions that were most likely to cause a problem for a patient, and this would be either causing a cardiac death, non-fatal MI, or requiring unwarranted revascularization, so unscheduled revascularization, these lesions would be ones where you'd have a high plaque burden. So they'd have a plaque burden index on intravascular ultrasound of greater than 70%. And they'd also be associated with thin capped fiber atheroma. And if you had these type of plaques present, then you're more likely to present with, a recurrent event, more so than a stenosis within your coronary epicardial vessels. We have found similar to that, then actually, it seems to be the features of the plaque itself that are more akin to predicting events rather than the luminal stenosis. And this was work that Michelle Williams did using a retrospective analysis of the Scar Heart study, where if you look at the composition of the plaque, and you look specifically at those that have positive remodeling and those that have non-calcification plaque within them, so they're particularly the lower attenuated values, the low attenuation non-calcified plaque, they're the ones which are most likely to result in a patient coming in with another heart attack. Actually, when you start to quantify this, then that becomes an even more robust way of doing future risk prediction. So if you have a plaque burden that is over 4% for low attenuation non-calcified plaque, you're over threefold more likely to come in with a cardiovascular event than those who don't have these higher plaque burdens. And that's similar to what we're seeing with fluoride. So we're seeing a twofold increase risk in those who are coming in following a heart attack compared to those who don't. Obviously, there were differences between our cohort, the preferred cohort, and Scott Hart. Scott Hart was in those coming from the rapid access chest pain clinic. So they didn't necessarily have a heart attack at the time that they presented. All of ours did. And so, trying to discriminate between those two may require slightly different techniques. I guess the question on people's mind is, can all of this be done with cardiac CT? And you and I know that cardiac CT in patients who've got stents in their epicardial vessels, as well as those who've got really complex multi-lesion disease, can be really challenging CTs to interrogate. And we've certainly looked at plaque quantification in these patients, and actually doing quantitative plaque analysis in patients who've got a high or very advanced amount of atheroma can be a real challenge. And actually the metrics that we use, like total plaque burden, non-calcified plaque burden, calcified plaque burden, and low attenuation plaque burden, don't have as good reproducibility when you get into these high numbers. And that's just because motion artifact can play a bigger issue, whether you're getting a vasodilator response to GTN in the context of having a metal scaffold in place, making sure that you know where the limits are between where that scaffold starts and ends, so that you can still account for all of the residual plaque that's present within the coronary tree, are all challenges that are faced by people who are involved in the field of quantum plaque imaging. Obviously, we're trying to improve all of these algorithms going forward so that we can do this in a robust way. But the fluoride scan is actually a really simple way of doing it. You're really just looking down the coronary tree and you're seeing whether you've got hotspots of disease activity that are either present there, they're really high, or they're not. And that's actually a really cleaner way of trying to look at these patients with really complex coronary anatomy compared to some of the quantitative tools that are out there.
Okay, so I guess the question is then begged, is fluoride PET ready for clinical prime time, or do we still need more validation? And, in line with that same question, can you describe any ongoing studies that are of note right now involving fluoride PET imaging?
So I think one of the things that translates a technique into prime time is more than just doing risk prediction, which is what a lot of imaging studies have done to date. It's what actionable management will result from doing that imaging test. And at the moment, we don't have any clear guide as to how we could further lower a patient's risk if we did find that they were at elevated risk following their MI. Should you go on to then use therapies like a PCSK9 inhibitor? Should you think about the immunomodulatory therapies that are coming online? Well, we haven't done randomized control trials in patients who have fluoride activity to know whether that is the right way forward. But I think that would be the natural extension of this work. And certainly we'd be very excited to see new agents coming online where they've been tested using these metabolic tracers, if only to say, can we dampen down metabolic activity within the coronary arteries? Because if 60% of patients, after having their stents put in, after having intense medical therapy started following a heart attack, 6 out of 10 of them still have really high fluoride activity. So they've got really high disease activity. So clearly more needs to be done for them. What those agents will be, hopefully we'll find out in the fullness of time which trials and which agents will be able to modify disease and therefore confer the benefit that we want for all of our patients.
Wonderful. Alastair, thank you very much. I know this is a bit of a non-traditional view for our podcast to extend beyond the boundaries of CT, but there's a lot of overlap between the work that you've been doing and the efforts in the cardiac CT community. So really thank you for your time. Thank you for the science that you've contributed to our community as a whole. Wanted to ask if you had any final thoughts before we conclude.
I think one of the things that our listeners are probably already well aware of is that we are clearly very big cardiac CT enthusiasts, but there's a really strong requirement for multimodality images going forward in the future, and actually being able to combine these type of modalities where you can then provide hybrid imaging is going to be really attractive for our patient groups, because you get a lot of the structural information that you can from a CT or potentially even from an MRI scanner now, if you're interested in myocardial mechanics and how the heart works. But laying that on top with nuclear imaging in the form of positron emission tomography, where you can look at disease activity, is a really way of being able to assess everything at once. And I think that the fact that this isn't necessarily just a research technique, it can now be done within clinical settings, is really exciting. And so I'd certainly encourage our listeners out there who are at early stages of their careers, if you get the opportunities to learn how to do hybrid imaging, I'd be a strong advocate for that.
Fantastic. Thank you again, Alastair. And for our listeners out there, thank you. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. Once again, this is the Donut of Destiny. Cheers.